Okay, respiratory number 2, picking up right where we left off with respiratory acidosis. So after you connect your patient to the monitor, 5 lead or 12 lead, either is fine, so that you can monitor their arrhythmias, dysrhythmias. You're going to notice neurologically that one of the first signs is headache, and maybe tired or lethargic. And then as this imbalanced respiratory acidotic state continues, then your patient will become more and more neurologically impacted. So you'll see drowsiness, dizziness, and then eventually disorientation, maybe with some agitation and aggressive behavior. Eventually, the patient will become unconscious, and then eventually death can occur if we don't reverse this imbalance. So that's how a drug overdose patient would pass away from their drug overdose. They begin to breathe rapid, shallow respirations, and they become more and more acidotic, and eventually their heart will stop beating. Next, we're going to look at respiratory alkalosis, and we know that the patient, when I discussed in class, where you're driving down the freeway and you hit the dog and you start hyperventilating because of the incident. So you're tachycardic, you're lethargic and confused starts to occur from the respiratory alkalosis stage. Literally, you're breathing and not a quality breathing. It's a deep, rapid breathing that will cause you to lose more CO2 than you are taking in, and so you're increasing the amount of bicarb that's in the system versus decreasing the amount of carbon dioxide. So in order to equal or balance this respiratory alkalotic state, you will need to have your patient reabsorb the CO2 that's missing from their body. And the way that we can do that is we will have them breathe into a paper bag if possible. By breathing into this paper bag, you'll notice that this will allow the patient to reabsorb that CO2 that's missing. Calming them down also is a secondary helpful thing to do, having them calm down so that they don't continue to breathe off more CO2 than what they're taking in. And once they start to calm down and they start to reabsorb that CO2, their lightheadedness will go away. The tachycardia should slow down and eventually be within the normal range. And sometimes with respiratory alkalosis, we'll actually see a patient have nausea and or vomiting, as well as numbness and tingling in their extremities. You'll have a patient who is respiratory alkalotic have an increased pH above 7.45, and their, again, CO2 is below the norm, so it would be below 35. Other causes of respiratory alkalosis would include when a patient throws a PE. So that is also an imbalance in the amount of oxygenation happening in the body, so lack of carbon dioxide, right? Due to the anxiety, again, from the fact that the embolism is in their lungs, causing them extreme pain, and the patient knows that what they're feeling is not normal. So anxiety, PE, fear, and then finally, if we have a patient who is on a ventilator to help them breathe, if we don't have the vent settings right, then we could potentially cause this imbalance to happen due to our interventions and our settings on the ventilation. So we got to make sure that the vent machine, the ventilation is accurate for the patient. So again, treating this patient, you would include calming them down and having them reabsorb the CO2 into their system. Once they do that, then the side effects, their breathing will return to normal. It will not be labored. It will not be rapid. It will be quality breaths with equal dispersion of oxygen as well as carbon dioxide. They will no longer be tachycardic. They'll have a normal heart rate. Their blood pressure will return to a normal range, and there will be no numbing and tingling of their extremities. Their neurostatus will return from confusion and lethargic to alert and oriented back to their baseline, and then your patient is stable. The next one we're going to look at is metabolic acidosis, and this is where a patient has an increase in the amount of hydrogen ions being retained in the body, and therefore there's a decrease in the amount of bicarbonate in the body. Many times we see this when our patient has severe diarrhea for days. Other times would be renal failure, diabetic ketoacidosis, and or shock. So you have the decreased ability for the kidneys to get rid of the acid, or even the kidneys' inability to conserve the base. So we have a pH that's below 7.35 and a bicarb that's below 22. And you'll notice in your patient that they'll have a headache, and they'll have a change in their level of consciousness. Specifically, you'll see confusion, drowsiness, lethargy. Their skin may be flushed because it's due to the vasodilatation that's happening. You might also see some nausea and or vomiting in this patient that could or may not be present in all patients that have metabolic acidosis. You will see muscle twitching, their blood pressure will be low, and they will be hyperkalemic. And the body attempts to correct this imbalance by having a compensatory hyperventilation. And those respirations we refer to as Kussmaul respirations. Remember, that is a compensatory hyperventilation due to the metabolic imbalance that's happening in the body. Next we're going to look at is metabolic alkalosis, and this is where we have a decrease in the amount of hydrogen ions in the body and an increase in the amount of bicarbonate in the body. And we will usually see this type of a reaction when a patient's been vomiting for several days. That will cause this imbalance in the body. And if it isn't due to severe vomiting, it is due to nursing going in and being too aggressive on the GI suctioning. So we will literally set our GI suction and be too aggressive with it. So we have suctioned out too much acid out of the body, causing this decrease of hydrogen ions and increase of bicarb. Additionally, we can cause this imbalance to happen if we get too aggressive with the diuretics given to the patient, or it can also be caused when the patient takes too much sodium bicarbonate on their own. So too much, again, sodium bicarb. You'll notice that these patients will be tachycardic, and therefore they will be at risk for having a dysrhythmia. They'll have muscle cramps, tremors, tingling in their fingers and toes. This is due to their hypokalemia. They might also have a side effect of some diarrhea as well, but you they'll still, this whole time they have nausea and vomiting. Increase in their pH, so their blood's going to be above 7.45. And of course, we already stated an increase in the bicarb, so an increase in their HCO3. And neurologically, you'll notice they'll be restless. So they'll be shaking their legs, jiggling their legs, fidgeting with their hands, and then that'll be followed by a decrease in their LOC and lethargy. They may get dizzy and become very irritable and combative. And so we need to watch our patients really closely with this. There are definitely going to be fall risks and having a risk with their cardiac status as well. The lungs try to compensate by hypoventilating with this imbalance. And how we treat this is literally we will determine what's the causative factor. If we're too aggressive on the suctioning, then we'll turn that off and let the patient level out. Or if it's severe vomiting, then we'll give them an antiemetic, like ondansetron, and then we will again reverse that status with the patient. Many of the tools that we use for doing exams, one of them is called a bronchoscopy, and this is where a physician will pass a flexible scope down a patient's throat through their bronchi into their lung, and they will literally scrape the lung and get a piece of it for cytology. And what they're doing is they're looking for any abnormalities that exist in the lung, or they're removing any kind of excess secretions that might exist in the lung. And you, as the nurse for the patient who's getting this exam, will ensure that the patient has been NPO for at least 6 hours, preferably 8, that the patient is sitting in a high Fowler's position the entire time for the scope. And just be aware that the patient, the physician sometimes does this at the bedside, so we want to make sure that we're providing privacy. Again, ensuring that patient has had nothing to eat or drink for at least 8 hours, 6 to 8 hours, and that they are in the high Fowler's position. And then post bronchoscopy, we're going to be watching the airway really closely. Anytime that we do any kind of procedure where we have utilized the trachea and throat, we're going to watch it closely to make sure that they don't have an adverse reaction and that we don't lose our airway. And then, of course, we want to make sure that before they stop eating and drinking, that they get their gag reflex back and that they can swallow safely without aspirating, because they're going to be at a higher risk for aspiration pneumonia. So that's important as well. When we also can do a sputum sample as an exam, a tool that the physicians use. And again, with this tool, we're going to make sure that the patient is actually expelling the sputum and phlegm, and that they're not just spewing out saliva. So we're going to make sure that the phlegm is actually yellow and thick and that it's not watery like saliva. We're going to collect it in a sterile container, and it's going to be tested to see which antibiotics it will be susceptible to. We will do a gram stain to detect the bacteria in that sample. And if for some reason the patient's unable to expel the sputum, then what we'll do is we will use a suction machine that's clean and new and actually suction out a sample to be tested. And again, this is we're looking for bacteria that is in this gram stain and culture, and we're looking to see what antibiotics the bacteria infection will be susceptible to, so that we can give them to this patient and we can fight off that infection.